Hello, how you doing? My name is Tajay, and I'm happy to present the Scientific Inquiry Health Professions Team Research Design Proposal Presentation. My team consists of myself, Tajay, Noel Alfonso, Jasmine, Nadia, Versace, and Gabriella Rivera. Our research idea: how will simulation-based training affect the medical errors in the medical facility? How will it affect patient safety and employee work efficiency amongst residency with utilizing EHR systems? We're going to place emphasis on the main aspects of healthcare, which is access, quality, and cost. And in our literature review, we've seen that prior studies focus on the usability of EHR systems after simulation-based training. But we're like, how is this relating to the access, quality, and cost? Introduction. Simulation-based training is basically utilizing computer software to reflect real-life scenarios. And prior studies has conveyed the positive influence of simulation-based training for the usability of EMR EHR systems. Prior studies emphasize the need for further studies to dive deeper into aspects such as simulation-based training for EHR usability and its impact of patient safety, how it impact and prevent medical errors, and how it impacts employee work efficiency and satisfaction. This called for the need for a study that will focus and assess interprofessional workflows, patient safety, and other quality-based aspects. Statement of the problem. Prior research on simulation-based training focused on the usability of EHR systems, such as the knowledge that employees have. But prior research did not assess the impact simulation-based training for EHR systems have on access, quality, and cost of healthcare, which is the medical facility's performance. The need for a study to assess the aspects mentioned above provides justification for what is the problem. What is the main problem? A study was needed to assess the impact of simulation-based training on the significant three aspects of healthcare I mentioned before, which is cost, quality, and access, all relating to patient satisfaction, confidentiality of patients' information, patients' waiting times, all things that aspect relates back to cost, quality, and access. Our focus on patient safety, medical errors, and medical personnel work efficiency will provide a solution to the problem. Because as I mentioned before, most of prior studies, if not all prior studies, focus on usability. But we're focusing on more than just the usability, but how the usability impacts the medical facility's performance overall. Significance of the study. The aspects the study will help shed light on is workflow processes, patient satisfaction, patient safety, employee efficiency, employee satisfaction, impact on medical errors, all relating back to access, quality, and cost. Because as I mentioned before, if the knowledge an employee gains from simulation-based training could further improve their knowledge of EHR systems, it goes a long way. Just the fact of being able to implement a patient's medical information faster into the EHR system will make it faster for a physician to see the patient because he or she will already have the background knowledge and better assess the patient based on the patient's medical history and things of that essence. Thank you.
My pleasure.
Before beginning the study, we asked ourselves why we need this study and what will it help us accomplish. First off, this study will help us improve the overall efficiency of our staff, both administrative and clinical, as well as improve the efficiency of the overall facility, which could translate to shorter wait times for patients and a reduction in medical errors. By choosing a teaching tool that is effective in getting key information across to staff, they will be better prepared for real-world application outside of their trainings. Learning a new system is quite a daunting task, and many people do not take well to change. Therefore, by identifying a teaching tool that makes the content more digestible and easy to understand, is key in increasing employee satisfaction and ensuring that staff do not become frustrated with having to learn a new way of doing things. Our hope is that this study leads us to a teaching methodology that can be applied to all the trainings done at the facility, even outside of the EHR. Whether it be new employee trainings or continuing education courses, everyone will benefit from utilizing an optimized training format. The purpose of our study is to identify if simulation-based training is more effective over other teaching methodologies in reducing the occurrence of medical errors and increasing efficiency of staff. We will use the outcome of the study to guide our facility in developing new training modules for staff. There are several questions our research will explore, including: is simulation-based training more effective than other teaching methodologies? Will the use of simulation-based training increase employee satisfaction when it comes to trainings and the ease of use of the modules? Does the use of simulation-based training lead to fewer medical errors specific to EHR systems? And how are access, quality, and cost affected by the utilization of simulation-based training? We hypothesize that simulation-based training will be the most effective for teaching a new EHR system and will ultimately lead to a more efficient staff, increased employee satisfaction, and a reduction in medical errors.
Literature we reviewed focused on simulation being a good tool for usability testing of EHR. We wanted to know if simulation training would actually work for our research project. Researchers A.B. Ladman and his colleagues found that simulation is a good tool for usability and safety testing of EHR systems. Usability testing is increasingly being recognized as a way to increase the usability of health information and technology. This study integrated the quality assurance version of an emergency department into their medical simulation center and piloted a clinical scenario in which emergency medicine resident physicians evaluated a simulated ED patient and documented electronically using the ED EHR. This study proved EHR can be successfully integrated into existing simulation centers, which may provide realistic environments for usability, testing, training, and evaluation of human-computer interactions. However, the problem we found in this study is that the researchers did not analyze workflow or usability data on the participant use of the EHR during the simulated scenario. The second literature we reviewed focused on simulation versus lecture-based training, which is the same thing that we would be focusing on. There was a comparison made between a group of residents who received lecture-based training and a group who conducted doctor-patient encounters in a simulated environment, measuring competence in communication skills. The group in simulation training evaluated the contribution of their training to their competency level significantly higher than the group who attended a lecture type of training. For the results, performance, attitude, and sense of competence of all participants improved. However, there was no difference found between the experiment and control group. There was no significant difference. So the family medicine residents from the experiment group evaluated the contribution of the training phase higher than the control group, and they did show higher satisfaction. Like mentioned before, the problem with the study was training and assessment of clinical communication did not include EHR-related skills. That's why there was no significant difference found between the experiment group and the control group. The third literature we reviewed focused on EHR-specific training because we noticed that was a problem. Oregon Health and Science University conducted a pilot study using simulation to train residents and fellows to effectively use EHRs in the intensive care unit. The purpose of this study was to identify errors in monitoring medication, laboratory, and vital statistics, and to help physicians deal with data overload and using EHRs. However, the problem with this study was Despite the development of comprehensive EHRs, we still see that there remain significant gaps in identifying dangerous medical management issues. This gap remains despite high levels of medical training. So, this suggested that the EHR specific training is beneficial in this situation. And lastly, we reviewed literature regarding the effect of simulation training. So we found that, well, researchers in this literature found that simulation did not increase self-efficiency of outpatient healthcare workers to use EHR. Simulation also did not increase the already high expectations about the impact of EHR. Standardized patients and the EHR training environment offered interactive learning, which we already knew, and physicians and nurses reported a positive view about simulation for EHR use, which we also knew. However, the problem with this study was that the results demonstrate that simulation training to use EHR can enhance healthcare providers' self-efficiency. But future research is still needed to examine the impact of simulation training on patient-centeredness, interprofessional workflow, clinical outcomes, and patient safety. Summary of the literature review. The main theory we found was that conventional classroom electronic health record training is often insufficient for EHR users. Studies suggest that enhanced training with hands-on approach and closely supported clinical use is beneficial. Gaps in the research. We found that there was hardly any EHR specific training. Also, self-reported efficiency may not have reflected actual efficiency. So someone that went through a training process can say that they understand through a questionnaire. However, it wasn't actually tested to see if they actually understood what they were doing in terms of clinical outcomes or workflow within a healthcare organization. Also, a selection bias might have been introduced in a few of the studies. As mentioned, a lot of the studies used residents. Those were recent graduates of medical school, or a lot of recent graduates of nursing schools. Those individuals seem to be more technologically inclined. Also, improvements in accuracy and efficiency during subsequent clinical care would enrich our understanding of the effects of the intervention. How does research fit in? We will provide a framework to examine the impact of simulation training on workflow and clinical outcomes. Also, we will determine whether participation in the simulation itself improve the use of the EHR systems. Strengths and weaknesses. The strength is proper knowledge of EHR systems can enhance the quality of healthcare, so this research is needed so that the quality of healthcare can change. As mentioned, the approaches were weak because they failed to determine the effect of the system on the quality of care. Our method will enhance the use of technology and ensure participants is able to make a valuable impact to healthcare organizations.
Hello, my name is Noel Alfonso. I'll be discussing methods, research design, variables, and population and sample. So to begin, we do have varying methods here. We have verbal elements only, visual and verbal, and the last one was practical, verbal, and visual elements. So to begin, verbal elements only includes just that, right? So we had education was distributed via verbal means only. So that means, we'd had a traditional classroom setting with an instructor and students. That instructor would then verbally teach the students using no practical examples, no visual elements. So again, this was an informational setting, meaning it was just verbal. The next one would be visual elements and verbal elements. So the education was distributed in a hybrid method for this element, right? So we had your traditional classroom setting still, but you also had PowerPoint elements. You had, that might include visual elements with worksheets. So visual elements were distributed, as well as those verbal elements from the first one. Okay, so then the last one was the practical, verbal, and visual. When I say practical, we mean like a simulation method where fake patients were built into the EMR. Then we allowed students to participate in that setting where they could work and practice on those patients in a safe simulated environment. That simulation was subsidized by verbal and visual elements. So that included, those PowerPoints, the worksheets that had those visual elements, and then we had the verbal elements, same as the second and first education delivery. Next, we have our research design. So, we established an experiment with statistically similar participants. Then we divided those populations into 4 groups, including the test group. So before I didn't mention the test group, but now is a good time to introduce that. We did have a test group that received no education training prior to the EMR shift, that is. So we allowed participants to go through each training track, right? One of the 4, the control, the visual, verbal, verbal, and then practical, visual, and verbal. So they went through the training tracks, they received that subsidized education, and then at the very end we allowed participants to be surveyed based on their satisfaction levels. A key point that I would like to make here is, and if we see at the bottom here, participants participated in EHR-specific training, like date interpretation and data extraction. So that's important to know because, that marks what the goal was for each individual training track. And I believe we mentioned it a little bit earlier in the PowerPoints. Lastly, we have our variables, and we did account for some. So the variables included each type of training the participant received regarding the new EMR. So as I mentioned before, we had the no education element, which is the first variable, and that was the control group. And I guess that would mark no variables, right? Then our variables included verbal education elements only, visual and verbal education elements, practical, verbal, and visual elements was the last one. So again, when I say practical, I mean that simulation training where the attendees were able to work on fake patients in the EMR and get that hands-on experience. They also received the verbal and visual education elements as well. And that brings us to our population and sample. Our population included participants from a major health system. All members of the health system were included in this, so we didn't discriminate against certain job duties. So clinical, non-clinical, and allied health, all that were working in the EMR received the training. In our sample, we did account for that fluctuation in departmental functional areas. So when we did this, we statistically accounted for varying levels of skill. So data literacy, I know, was 1. Education levels was 2, right? We would have gotten different results if we had all physicians in one class and then, maybe transporters or patient access all in another. So we did account for that, and we, made sure that they were all statistically relevant. So the sample included departmental areas varying in scope to include accuracy and representation in our study.
Quantitative research uses statistical analysis to obtain findings which include formal and systematic measurement and the use of statistics. Quantitative data, which is also known as metric data, exist in differing amounts or degrees and may reflect relative quantity or distance. This allows us to examine amounts and magnitudes of our research study. Quantitative observation is an objective collection of data which is primarily focused on numbers and values and is typically measured in terms of quantity, which can be used as a tool to make representations and interpretations about the test groups and overall study. The idea behind quantitative observation is to have results that are accurate, constant, bias-free, and improves reliability to credit the data that we obtain and the use of our study. For the data collection, we used a Qualtrics survey that was distributed via email to all of the participants in the test group. The goal of the survey is to measure the percentage of satisfied trainees from each of the variable test groups. The survey consists of 30 mixed scaled questions ranging from 0 to 10 that will fall under categories such as very likely to very unlikely, very satisfied to very unsatisfied, and no difficulty to much difficulty. This allows us to capture a numeric value that will match the feelings our test groups felt towards various areas of our study. This also allows us to measure the level of difficulty our system will have across a wide range of experienced healthcare workers, how receptive they are to using our systems, and the likelihood of companies recommending our system to other facilities.
So for the data analysis, we'll be analyzing the findings and the results. So just to reiterate a little bit, the participants, they were divided into random groups, lecture-based training and simulation-based training. And then the descriptive data that was found within the results and the groups, we divided them in age, gender, and then the mean scores, of course. And like listed before, the variables of non-education, verbal education, and practical. So as we'll be analyzing the data, the statistical analysis will be running through an ANOVA, and then if needed, the independent samples for a t-test we will run as well. And then of course all statistical analysis will be ran through SPSS. Reliability and validity. I was able to find a couple articles that use the simulation-based training and how it affected other aspects in different healthcare models. So the first one was influence of simulation on electronic health record use pattern among pediatric residents. So the results was that the residents were more likely to use the data visual tool after the simulation training. And then the EHR training they thought was an effective educational method that can change participants' use and patterns in real clinical settings. And then the other one that I found was visual electronic health record technology with simulation-based training course in acute care for pharmacotherapy courses. And as well, it was evident that they found that the simulation-based training, after they did the post-test survey, they agreed or strongly agreed that the virtual EHR simulation training increased their skills. So throughout the findings, it's proven that simulation-based trainings is actually a very highly effective way for people to increase their knowledge and use the skills that they learned. So that is our research proposal. Thank you.